I'd like really kind of your spontaneous, top of the head implications that you think and why. You want to start, Ken?
Why not? Well, I had sort of two takeaways. One is the opportunity here. If you think about it, just take readmission rates within a 30-day period of Medicare that are potentially preventable. Over the next 10 years, that's $250 billion that Medicare is going to spend on readmissions that we can potentially prevent. And secondly is that there are 6 conditions that are driving about 40% of the growth in Medicare spending. It's diabetes, high blood pressure, bad cholesterol, pulmonary disease, back problems, arthritis, and the 7th is depression. All of those are today unmanaged. The opportunity, I think, from what I heard today is twofold. One is that this is the latest set of data that I've seen, again from randomized trials, that shows that there are specific interventions that we can put into place today that we can replicate and we can scale, not designed necessarily by CMS, but designed by best practices that are already out there in the field, that do transitional care, that do medication reconciliation and compliance, that do health coaching, that do the transitional care models, that do the prevention models that could today save enormous amounts of money. So I think our challenge is, rather than sort of waiting to continue to do pilots and waiting another 5 and 10 years to get more results like this, I think we have a body of research out there of what's going on in the commercial market, what's going on in the Medicaid market, that over the next 2 to 4 years, we could scale and replicate these approaches in the Medicare program nationally.
Great, thanks. Senator Daschle.
Well, Ben, I congratulate you. I think this is, first of all, your presentation was excellent. I'd have 3 quick comments. First of all, I look at everything through the prism of cost, access, and quality. Does this improve access? Does it improve our cost equation? And can we find ways with which to improve quality? Across the board, this is a sweeping illustration of what you can do to affect those 3 factors. And that, to me, is really essential. The second issue, I think, is the fact that you've got a CMS seal of approval here. And I find that to be especially helpful with regard to the scoring that oftentimes occurs in government. Whether it's scoring on the Hill or scoring in OMB, we've always had difficulty scoring. But if CMS is going to stand by these numbers, that is really potentially very helpful as we try to begin scoring, which has always been a very, very difficult aspect of the scoring. Good prevention and chronic care management is something that I'm sure the 3 of us would agree is just a terribly frustrating experience. This could help. The third thing that I think it'll do is not that it's revolutionary, but that it's catalytic in bringing about, as Ken said, greater pressure, greater momentum to move in this direction more quickly. So I think it has huge consequences potentially for the ability to say, look, we've got a head of steam now. Let's seize on it. Let's not go back to the drawing board. Let's build on what we've got and make this the national model it deserves to be.
Great.
Yeah, I think to build on what Senator Daschle said, and the key question I'd ask, if I understood the briefing, is the CMS's internal scoring, in fact, doesn't validate this because they didn't include various considerations that the rescoring included. I mean, is that correct?
Partially. So on the original cohort, that's correct because the data I shared with you was the cumulative savings were below budget neutrality. Technically, MMA was written so that either any whole program or significant component of a program that met the criteria could advance this. So on the refresh cohort that I did put up there, the internal CMS scoring would, the report to us was net savings, along with all the other clinical and satisfaction data.
So Tom's right that you potentially have a CMS validation of essentially the difference is the participatory cohort versus the non, as I understand it. The non-participatory cohort raises the cost to a point where it ceases to be a net savings.
That's part of it. Part of it was also the technicality that you started with. CMS's scoring doesn't completely address the recognized anomalies in randomization on that endpoint measure. So you essentially have CMS scoring with two groups that aren't comparable. I think our chief scientist, Jim Pope, would say when you look at these kind of trials, you're talking about what's the power. You're an expert here on this type of thing, and that the scoring sits within a design and study that had randomization anomalies that would not leave it powered up enough in order to distinguish scoring on that.
Here's my question, having been down this road for over 20 years.
Yeah.
Because Tom's essentially right. There's a triangle that defines 80% of potential in this business. It's CMS, Congressional Budget Office, and OMB. Okay, I mean, if those three align, it's pretty easy. If they don't align, you have a chance, and if they align against you, it's really hard. And the question I would have is, if the technical experts got in a room and talked it through, is there a CMS letter that would say, yes, looking at reality as validated by a more sophisticated analytical model, this system clearly will, in fact, both improve outcomes and save lives? Or would they say, actually, the revalidation is not provable, and therefore we're still totally confused, and so what we need is another 10-year pilot? I mean, the difference in those two letters is night and day. Yeah. And what do your technical people tell you? I mean, have they talked back channel with CMS? Do they think there's any chance the CMS technical people would actually validate the rescoring?
We think that there is cooperative discussion on that, and that obviously CMS will wait until their independent evaluator puts out its final report to Congress. It would come later this year, early in the year. But this information that we presented has to be looked at as a part of that as well. So yes, we're working collaboratively with CMS. Is that letterhead there today? No. But I do believe that the results that have already been presented would afford them a mindset to say, if there's a clearer way to look at this, we certainly can't pass it by given everything.
And do you have any notion what the independent evaluator will be like?
I think they're a strong analytic firm, and I believe that it'll be hard for them to kind of ignore the analysis that I presented, largely on a couple of counts. As you know, this course and exact matching methodology is new. So during the course of the trial, it wasn't a part of the industry science, and it now is. And I think at the time, industry science that was contemporary was used to try to address these randomization anomalies, and now there are other techniques that will afford, as I shared with you, maybe a clearer picture. I don't know if you want to comment on the different statistical methods that are there.
I think everybody's head would hit the floor here pretty soon. But I think, to Newt's point, there were two issues: the balancing of the design, and the research methodology was this intent to treat method. So you had a control group, and whether you touched them or didn't touch them, that's what you're comparing them to. So this is a methodology that basically rebalances the design, and then it looks at the people that they actually impacted, the 2/3 of the folks that were in the control group, and compared them to a matched sample of people that they didn't touch. And if you look at it on an apples-to-apples basis, you see the types of savings that he's talking about. So I think that the challenge that I see is not only getting the CMS letterhead from this particular trial. The frustration I've had with them, and we continue to work with OMB and CMS and CBO, is that there are probably a half dozen other national randomized trials that CMS did not run, but they're national randomized trials that have very similar features to what you've seen here today that have shown that it works. And we know sort of the design features of why they work, how they work. We just need to sort of make sure that CMS and OMB, when they think about this, don't limit their mindset to things that they've actually funded through CMS, because there's a whole body of work out there that shows that these interventions can be very effective.